It's bad enough having one critical patient. Imagine having two, and one of them happens to be a newborn. Stick with me to the end. I'm gonna explain to you exactly why this really matters. Check it out. If I arrive on scene to a patient who needs to be transported to the hospital and she is pregnant, the very first thing I do as I walk into the scene safety, BSI, right? Then I start asking the patient questions. What questions do I ask her? I ask her, hey, how long have you been pregnant? How many weeks are you? If the lungs have not been fully matured because the patient is 32 weeks pregnant, it gives me an idea of what's going to happen to the baby when the baby comes out. It gives me an idea of what hospital I should take this baby to. If your protocol tells you take them to the nearest OBGYN hospital, the reason why is because at that hospital you have OBGYN doctors who are ready to retrieve this patient because you have complications like a prolapse cord. You have complications like a breech delivery. So when you're asking her these questions, you're trying to figure out how much of a complication can potentially come from this scenario. If she's having a contraction, you put your hand on it, it's going to feel like a bicep being squeezed. It's going to be really, really tight. And because the uterus is made out of muscle, it's basically giving a bear hug to the baby. And that bear hug could only go on for long enough until the baby comes out of the vagina. And the reason why the age of a pregnancy is so important is because a woman that starts to give birth above the age of 35 is considered to be a high risk pregnancy. There's a lot of things that can cause a high risk pregnancy, and advanced age is one of those. And advanced age is categorized as above the age of 35. There's plenty of women who give birth at the age of 40 and 42 and have a successful delivery, but the statistics show that having a baby after the age of 35 increases the risk for both the baby and the mother. And these are some of the reasons why this is more context for you as to why you want to ask more questions. Then after that is all squared away, we figure out whether or not how regularly the contractions are. If the contractions are every 5 minutes, it's not as urgent as having contractions that are every 3 minutes. We evaluate the contractions by touching, counting how long it lasts, and then after counting how long it lasts, once it stops, you continue preparing the patient for transport, and she'll notify you. You instructed her to notify you when you have your next contraction. Let me know. Then you go ahead and feel it again. Okay, contractions are now every 3 minutes. Contractions are now every 3 minutes, and they're lasting 30 seconds. Now you are like, okay, there's something else going on. It's escalating. We got here, they were every 6 minutes. Now it progressed to every 3 minutes. Does that make sense? That's trending. You guys ever heard of vital signs trending? Where it's kind of like you start with one vital and then you reassess every. The next thing you want to do after getting the information is check to see if you have imminent delivery. And how can you know if you have imminent delivery? One of the clues is how many times has she been pregnant? You'll hear things like GPA. G, how many pregnancies? P, how many of those pregnancies are alive? A, how many pregnancies were lost? So if a patient is, once again, G5, means she's been pregnant 5 times. P3 means that of those 5 pregnancies, 3 are living. A1 means that she lost 1. And if this is her 5th pregnancy and we've only accounted 4, that means she's pregnant right now. Does that make sense? If she is with that many pregnancies, the odds of her delivering the baby sooner than later are increased. Now we need to evaluate whether or not we should just transport her or deliver the baby right there. And how do we know this? Is there crowning or not? All due respect, you ask the patient if their water broke, have they seen any blood, are they feeling any contractions, and also now you need to visually inspect. Is she crowning? If there is no crowning, we're good. All right. But if there's crowning, whether you're in the back of the ambulance or at the patient's living room, you may need to prepare for delivery right then and there. So let's add up all these things. If she is 29 years old, her sixth pregnancy, she's 40 weeks pregnant, and she has contractions every 3 minutes. Now she said that her water broke and she's crowning. And on top of that, she feels the urge to push. Oh, yeah, the baby's coming. And what is that urge to push? The woman may feel like she wants to move her bowels. And in most instances, when that happens, you grab your OB kit, and the OB kit will have a suction bulb syringe. It'll have 4x4s. It'll have abdominal pads. You could have a towel. You can have different clamps. You'll have surgical gloves. You have a scissor, a scalpel, so you can cut the umbilical cord. So as you can see, I'm in the back of the ambulance real quick. These are the contents of what you could expect within a obstetric kit. I'm gonna open it up for you just so you can see. I don't want to open it up too much because I don't want to waste it, but basically you have all these things inside of here. Here are your sterile gloves. Here's your bulb syringe. Here's your scalpel. Here's your pad. Sponges. This is another wee pad type of thing. And here are the official names for everything. You got your apron, your OB towelette, your twist tie, your drape sheets. All that stuff is here. Check it out. This is what you could find inside of a pre-hospital OB kit. That OB kit will have a lot of different things. All right. So if I have all those risk factors that I mentioned stacked up, or all those clues stacked up, now I'm like, all right, I opened up the bag. All right, get the oxygen ready, put it next to the mom, maybe give her a nasal cannula if it's necessary. Go inside of this bag and grab everything you need, put everything where we need it. I'll grab the suction and prepare the suction for any suctioning that may be necessary. In most cases, there's not, but just have everything squared away in the living room, right? Or in the ambulance. So what is crowning? That's crowning. Crowning is you can see the baby's head. You guys see it? And the crowning will also have hair. But once again, we have all these things stacked up, plus the crowning. Deliver the baby. Get your OB kit ready. Get the stretcher ready. I'm handling this part. My partner is getting the stretcher ready, getting the ambulance ready, calling for ALS, doing whatever needs to get done. Make sense? But now the baby's crowning. Okay, imminent delivery. So you have issues that can occur while the baby is inside. Under the hood, for lack of better terms, are mostly all related to the mom. Eclampsia, diabetes, may or may not be taking prenatal vitamins. All those issues will affect the baby, but under the hood. Make sense? Then you have pregnancy complications that occur as the baby's coming out. Then you have complications that occur when the baby is out. We've already discussed some of the ones that occur while the baby's inside. Now the baby's coming out. Complication number one. Remember, you have an anus. Gentlemen, you have your anus, and then you have your testicles right there. There's a space between your testicles and your anus, which is the perineum. In ladies, it's the anus and then the beginning of the vagina or the vaginal canal. That's the perineum. That can tear. If the baby comes out too abruptly, it'll tear it and cause bleeding. That's a complication. In the hospital, there's something called episiotomy, where we consciously put lidocaine around the baby, around this area, and cut it at an angle to avoid the pudendal nerve, so that now there's more space for the baby to come out. So sometimes this is cut and then this sutured back up, but it could also rupture spontaneously. So that space, once again, from the anus to the vagina can tear. Also, another thing that they do in the hospital is they'll do an epidural, and that's usually around the waist area at the sacral or lumbar spine. The anesthesiologists know exactly where it's at, and it'll cause the lady to have no feelings from the waist down. So that's an epidural. They do that at the hospital. I'm just giving you the context so you could understand it. So, but we're delivering it. We have no epidural, none of that stuff. So the best we can do, believe it or not, is with a gauze, knowing that it can tear, apply pressure as the baby is coming out. When should the baby be coming out? When should you encourage the mom to push? Have her push during the contraction. You have a contraction coming up? Okay, push, 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 push. Now, during that push, they have the urge to move their bowels. That push may produce fecal matter. That's why you have one of these. That's not the only reason you have it, but if she happens to literally defecate on top of this, you remove it and then you put another one. There will be, especially if her bowels are full, there will be fecal matter. Prevent the tear. Now the baby's coming. The baby's crowning. This is what's going on under the hood, by the way. You got the placenta under the hood, under the belly, inside of the uterus. You have the placenta. This is the baby's life source. This gives the baby everything it needs. This delivers after the baby. If it delivers on scene, you take it with you to the hospital. Through here is where the baby breathes. Through here is where the baby gets everything it needs. And it's connected to the umbilical cord. That's what's going on during pregnancy under the hood. The umbilical cord needs to be taken care of. The placenta needs to be taken care of. I'm going to show you when that time comes, but just giving you a context of what you see under there. If the baby's crowning, you guide the baby out. How do you guide them out? You guide them out by putting these fingers in between the baby's neck. So once the head comes out, usually it'll come out with a shoulder. So remember, we're preventing the tearing. Now we're guiding the baby out. It's all supportive, right? We're just supporting. But we're being mindful. We got to have a towel. The baby's slippery. Guide the baby out with your hands in here and up. Now, when you pull, be careful not to pull hard. You guide them out. It's kind of like you apply pressure or pull, but not like that. It's more like a gentle encouragement type of thing. Does that make sense? So, pull out. The shoulder will deliver. Usually the first shoulder delivers. The arm comes out. Then to get the other shoulder out. Now, just to clarify, when guiding the baby out, you're not pulling like I mentioned. And when you're guiding them out down first and then up. Once again, you're guiding them down towards the bed, towards the stretcher, and then up towards the sky, towards the lights. When you pull them down, that's the anterior shoulder will be delivered along with the baby, and then when you bring them up, the posterior shoulder will bring the rest of the baby all the way out. And always remember, have a towel in hand to not only keep the baby warm, but also to be able to grip the baby a lot better, because they're going to come out extremely slippery. Let me stop here for now. Guys, understand, there's people that study 5 to 7 years to understand this. You're not going to get everything you need within 45 minutes. Get your money's worth. You have this mannequin at your disposal during your downtime. Come back and practice it, because this is a very common call type for BLS. In New York City, as paramedics, there's not much we can do. As paramedics, we give them fluids and transfer them. So that's all we can do for this and trauma. That's why BLS is usually in charge of OB emergencies and trauma calls. It's not to say that you shouldn't call for ALS backup. I'm just helping you understand. We paramedics don't carry a medication in this drug box that's going to make all of this go away. So if you are not confident with this, it's totally understandable. Remember, you got about 2 months left to your EMT program. So you have time to remedy your weaknesses, all right? Now, this is for educational purposes. You got to get your hands-on skills. So with delivering, right? With a towel, with something, because they're slippery. Slippery when wet, right? They're going to come out. You guide them out. Now the baby's here. We spoke about the complications of the mom. Then we started talking about the complications of the delivery. We spoke about preventing the tear. Let's go to more complications. If this baby comes out with a pulse rate below 60, you start CPR. If the baby comes out with a pulse rate between 60 to 100, you start ventilating. With a BVM, you start providing oxygen via blow-by oxygen. If the pulse rate is above 100, then there's no need for aggressive intervention in the majority of cases. You apply the APGAR. So when we talk about APGAR, what is the first A? The first A is appearance, the patient's color. P, what is the P for? The pulse. What is the G for? The grimace, whether the reflexes. A for the activity, and R for the respirations. These are done in the first minute of birth and at the 5th minute of birth. If you have a score between 7 to 10, then that's a good score. If you have a score that's below that, that score requires intervention. The intervention could be simple as providing ventilations or as aggressively as starting CPR. You can have a score of 0. Here's the picture of it right here. So the baby comes out. You kept them warm. You're stimulating them. You hit them in the butt. So you suction, squeeze, let it out. Then the nose. Boom, squeeze it out. Boom, keep them warm. Everyone's trying to stimulate the baby. Now he's suctioned, right? The baby may have meconium staining. It's signs of fetal distress. Well, you clean them up, whatever. Let's say it's a normal delivery. After you clean them up, now you got to cut the umbilical cord. You place the first 6 inches away from the belly button, then the next one about 1 inch after that, and you cut in between. Remember, the OB kit is going to have a scalpel or a scissor. So we cut, boom. After cutting and keeping the baby warm, and you do your APGAR score. So you do your APGAR at 0 minutes and then 5 minutes. That's another example of vital signs trending, right? Once you do that and the baby's stimulated, you cut the umbilical cord. Now the placenta will deliver, but maybe not immediately. But one thing you could do once you reach this point is expose the mom's breast and have the baby ideally connect to the breast. At this point, the baby's warm. You got the hat on him, you swaddled him, you dried him up. Now he's attached to the mom's nipple. Why? Because there's something called oxytocin. And that oxytocin, not only is the baby being fed, right? He's eating already. It calms him down or her down, but also it helps the mom control the bleeding and deliver the placenta because this sends a signal to the brain that helps all that. And a quick word on oxytocin, just so you guys can know there's a lot more to mention. But remember, this is a basic life support video, and that's beyond the scope of this video. It's just an introductory information because I've said it before and I'll say it again. It's one thing to be told what to do, but if you understand the why behind it, at least in one sentence, it makes it a lot easier to make the right decisions. So once again, memorization and doing what you're told is great, but if you add a layer of understanding, it's even better. And that's why I want to give you that little bit of explanation. But there's a lot more to say, but we'll keep it at that. Let's continue. Through a hormone called oxytocin. So breastfeeding and breast milk is liquid gold for babies. Liquid gold. You said you eventually want to have a child. Make sure that your wife will always breastfeed, and she may be discouraged for breastfeeding because, hey, I'm not producing enough milk. It's something that women say often, but there's something called the positive feedback loop that causes that the more the stimulation is occurring, the more it increases the odds of it producing. But there's a period between the production and the stimulation, and people quit at that stage where it's kind of like, hey, it's not producing, I give up, let's just use formula milk. No, if you would have stayed the course and continue to let the baby suckle, eventually you produce breast milk. So that's normal delivery. Again, the problems that could occur when the baby's here are related to the mom, and it indirectly affects the child. As the baby's being delivered, now it's affecting both of them. What affects the baby when he comes out is that we can fix is give oxygen, start CPR, connect them to the mom, to the breast, and start keeping them warm, put a hat on them. All right, guys, how's the information so far? Is it digestible? All right, good. Now, when you're dealing with family members on scene for these type of calls, they're most likely going to have a go bag, a bag that they use, that they have ready to take to the hospital. So get them to, and they usually use the name go bag. When my 3 kids were born, we always had a go bag. So you tell them, get the go bag. If the family is acting irate, if the family is very emotional, give them something to do. They usually want to help. Go get the go bag, go get the papers, do whatever it is, start delegating responsibility. The emotions are going to be very, very high. And if you're not going to have to deliver on scene because there's no crowning, then start giving people what to do because they're most likely going to be very, very frantic. So once again, ask them to go get the go bag, ask them to start moving things along so that you can get the person and the baby and the mom over to the nearest hospital as soon as possible. So there's many different things that can go wrong. But let's talk about some of the most common. One of the most common is prolapse cord. It's supposed to be crowning, but now it's a prolapse cord. One of the only times EMS providers are allowed to put their hand inside. One of the only times we put our hand inside and lift up. Why? Because this is the baby's life force. Remember, it's connected to the placenta. Remember, this is what gives them oxygen. If this is being clamped down as if there's a tourniquet, if this is being clamped down and preventing the supply, what's happening is the baby's being affected in a negative way. So this is why we're putting our fingers in and creating space. This is go ahead and take the pressure off the umbilical cord. So prolapse cord, that's a prolapse cord. Next thing that can go wrong. Remember, you have the hips and then you got the pelvis. If for some reason the baby, remember I told you before, the baby comes out with one shoulder, but sometimes he'll be stuck and both shoulders are inside. And most people, they'll lose patience and start pulling on the baby's neck. You don't want to do that. It's not a turtle, you know what I mean? That's shoulder dystocia. And basically what's happening is both shoulders are inside. What this person needs, ideally, is OBGYN tending, a person who already went through residency and went through all the process and they know exactly how to fix this. So that's shoulder dystocia. When you have shoulder dystocia, what you want to do is do the McRoberts maneuver. You want to call for ALS. You also want to create or help with suprapubic pressure. Basically, you're going to bring the patient's knees all the way to her chest and try to help as much as possible. But the main gist of this treatment is you transport while treating. Do not wait on scene. Expedite the transport because once again, this is one of those abnormal complications or one of those complications to a normal pregnancy. So once again, look up the McRoberts maneuver because now I can't demonstrate it since I'm in the back of the ambulance. Look up the McRoberts maneuver. Look up the maneuver of or how to do suprapubic pressure, call for ALS, and treat while transporting. Next thing, you may have a breech delivery. Remember, guys, we want to see crowning, the top of the head with the hair. But you may have this. This is another issue that can happen. Or it may be the buttocks, and all you see is the butt. So these are complications, abnormal pregnancy complications. Or you may have the head comes out and now the cord is wrapped around the baby's neck. If that happens, you don't need to get nervous. Just unwrap it. Unwrap. But obviously it won't be this simple, but you may not be able to unwrap. In that case, if you're unable to unwrap it around their neck, then you apply the clamps and you cut. So we spoke about the problems that can occur when the baby is here: eclampsia, preeclampsia, gestation, being elderly gestationally, not taking the prenatal, high blood pressure, diabetes, obesity. These are all risk factors. Obviously, if the mom drinks or smokes, all that stuff, how many weeks pregnant she is. Then when we're delivering the baby, we have the tear, we have the prolapse cord, we have the cord around their neck, we have shoulder dystocia. There's a laundry list of things that can go wrong, but these are some of the most common. Then when the baby comes out, the complications that we can have at this stage is that the baby's heart rate is below 60. Then we do CPR. Or if the heart rate is between 60 to 100, then we ventilate and give oxygen. But with babies, if you do the neonatal resuscitation program, you'll notice that one of the main treatments that we give them when they're in fetal distress is just oxygen. Ventilate them, use a BVM if you have to, give blow-by oxygen. Be mindful, you don't want to give them like a bunch of oxygen because it can make them blind, right? So you'll put like oxygen blow-by in the area. So it'll be like a nasal let's say this is a nasal cannula, it'll be like in the area as opposed to like, just be mindful.
Go, it's coming, it's coming.
Slowly, at this point, you're gonna go slow. You're gonna.
All right, big deep breath.
No, go a little bit at a time. Go. A little bit. Push. Slow and steady.
Little pushes.
A little bit at a time.
Slow.
There you go.
We got the sound before.
All
right.
We got
Push a little
all
more.
the hair.
Good.
Look at all the hair. Oh my goodness. All right, we got the hair out. So,
Hey, my skin. Hi.
we did it about 31.
I know. Congratulations.
Yes, yes.
Why do you look so cute? It's gonna get her a little dry. You can hold on to it, okay? Yeah, tell us. Welcome. Did you enjoy that journey?
Welcome to the world. In a minute.
Tiene pelo rizo.
Great for being a hero.
Great.
Oh my God.
It's a little harder for you.
Some people push for 3-4 hours and the baby comes.
It's a much harder way to
The
push.
baby was facing up.
Yeah.
And I said, I hope this baby turns.
You did it. She did great. She
has hair.
We told you she had hair. We knew she had hair.
Is that made it already?
Yeah, you're
Okay.
Fine.
We're gonna cut.
You want to cut the cord? Do you want your family to see?
Of course.
Give me the video.